we good? Good? Okay. All right. So welcome back, everybody. This afternoon, we're going to discuss how to define a good prediction study. And this is following up from this morning session where we discussed how to use cohorts to produce characterizations. Now what we want to think about is that we can use cohorts to define good prediction problems. So what we're going to do is I'm going to talk to you very briefly about laying out to lay out a way for you to think about different types of prediction problems that are important in healthcare. And then we're going to do an exercise this afternoon where each of you are going to need to define a prediction problem. And then you're going to talk amongst yourselves in groups. And then we're going to discuss the different prediction problems that you come up with as a class. So I've shown this picture before, but I want to bring it back to reinforce the point that we're drawing. When you create a cohort is a set of people who satisfy a criteria for a duration of time. A cohort has some entry event. That entry event can be thought of as time zero. And by having a cohort entry at some time zero index event, it means you can split the time in someone's life between everything that happened before the index date, that's your baseline time, and everything that happens after that index date, that's your follow-up time. And this general idea of thinking about data over time and splitting it into activities that happen before and activities that happen after is very fundamental to how we think about using the data. When we were describing characterization, we had an index date of women with endometrial cancer, and we did a characterization to describe everything we observed before that date. But then we looked forward to see how many of those patients got lymph node metastasis. So this picture is important, and you'll need to be thinking about this picture as you define your own prediction problems. So another quiz for all of you. With this one framework, there's lots of different questions that you could ask. We could use this data to ask questions like, which treatment did patients choose after a diagnosis? Which patients choose which treatments? How many patients experience the outcome after treatment? What kinds of questions do you think that those are? Characterization. We could also ask the question, what's the probability that I develop this disease? So basically, who gets into the cohort? Or I could ask the question, what's the probability that I will experience the outcome? So what happens to me after I'm in the cohort? What kinds of problems are those? Prediction problems. And then the third set of questions, you can have questions like, did this treatment cause an outcome? Or did one treatment cause an outcome more than some alternative treatment? So what types of questions are those? Estimation. Okay, good. So you have characterization questions, prediction questions, and estimation questions. What we're going to focus on is think about some of these prediction questions and what makes for good prediction questions that could be impactful in healthcare. The way to think about all prediction questions, though, is that you're taking that cartoon of someone's medical history and you're cutting it at time zero, and you're only allowed to use the information in the past to predict something that's going to happen in the future. This is very important because if we're going to develop a prediction model, the purpose of a prediction model is to apply it in healthcare. So for those of you who are planning to become doctors, you would like to use a model whereby you know something about the patient in front of you, and you're trying to say, given everything you know about them up to this moment in time, What's the chance that something's going to happen to that person sometime in the future? So when we design our prediction problems, we have to be modeling that same exact activity as how we would use the model in real clinical practice. Very frequently, if you read published papers that say that they are doing prediction, they don't follow this rule. And you'll find that sometimes they're using variables that you only learn about after time zero to predict the outcome. That is not scientifically valid to do. Because if you're going to use the model at time zero, that means, for example, you get to know everything about your patient as of this moment in time, but you can't use information about what's going to happen to the patient next month because it hasn't happened yet. So you need to be able to know that you can only use the information up to a moment in time to predict something that's going to happen in the future. The most important thing actually about defining some sort of prediction problem is being clear about the moment that you want to make the prediction and to know what information do you know about a person at that moment in time, and to clearly separate that from what's going to happen in the future, which is the outcome you care about predicting. So all prediction problems can follow a general framework, which is going to say, amongst a target population, so think of that as a cohort, you're aiming to predict which people in that cohort will experience some outcome during some time at risk window, which is the span of time that you're going to look after the index date to look for the outcome to occur. All prediction problems can be framed in this way. What that means is that you actually only need to define 4 things when wanting to specify a good prediction study that you'd like to do in observational data. You need to define a target cohort, so that's the people that you want to produce a prediction for. You need to define an outcome cohort, so that's the outcome that is experienced sometime in the future. You need to define a time at risk, which is the window of time that you're going to look for the outcome to happen after being in the target cohort. And then you need to specify a model, which means decide what type of statistics you're going to run in order to train this prediction. For purposes of today, we're going to focus only on those first 3 categories: defining your target cohort, defining your outcome cohort, and defining your time at risk. Tomorrow, I'm going to give you a lecture about how to think about the statistics of specifying the model. So every prediction problem that we're going to do can simplify down to this. And if you've heard anybody talking about advances in machine learning and artificial intelligence as hot areas in informatics or data science, they can all be simplified down to this very simple format. You're trying to predict the future for patients based on what you know about them in the past. That is how all predictions in healthcare can be simplified too. I'm going to walk you through 5 different types of prediction questions that we believe are important in healthcare that need to be done. And I'll provide you some examples. And so I'm going to walk through each of these one at a time. The reason I'm sharing these with you is because I want to provide you a template that you can follow to think about how you can write your own prediction question simply by filling in the blanks for the prediction problem. So the areas are disease onset and progression, treatment choice, treatment response, treatment safety, and treatment adherence. But I'm going to walk through each of these one at a time so that you can really take some time to think about it. So disease onset and progression. The fill in the blank statement that you could think about is, amongst patients who are newly diagnosed with some disease, which patients will go on to have some other disease in some time horizon? And so if you are interested in studying or predicting disease onset or disease progression, all you need to do is fill in the green, which is your target cohort, the red, which is your outcome cohort, and the purple, which is your time at rest. Those are the only three things that you need. An example of this would be, amongst patients newly diagnosed with atrial fibrillation, which patients go on to have an ischemic stroke in the next 3 years? That would be an example of a disease progression prediction problem. And it turns out that there is a well-known prediction model for predicting stroke called the CHADS-2, which if you haven't learned about in medical school yet, you will, because it's a model that clinicians are taught, which determines how to treat patients with atrial fibrillation based on their predicted probability of getting a stroke in the future. And that, in fact, started with a prediction model out of the databases, just like what we're talking about. Another example of this would be Bonnie's question that we're focused on. Amongst patients who are newly diagnosed with endometrial cancer, which patients will go on to have lymph node metastasis in the next 1 year, was what we started with this morning, or we could define it elsewhere. In general, I'm going to guess that probably 75% of the prediction problems that have been published, and many that still need to be done, fill in this template. This is the problem that we're interested in. Because for those of you becoming medical doctors, the moment in time that you see a patient is probably because the patient has developed some disease, and you are thinking about what to do for that patient. And the particular concern at that moment in time is you want to treat them immediately for the condition that they've come in with, but you're also worried about what is going to happen to that patient in the future. And so if we had prediction models that could tell us what's the chance that bad things are going to happen in the future to your patient, knowing what the chance of bad things happening could guide your treatment choices. If you knew that a person had a really high risk of ischemic stroke, then you would know that you're going to provide an oral anticoagulant to that patient, because that is a known treatment to reduce the risk of ischemic stroke. So as you're thinking about your own prediction problems that you might be interested in, think about clinical scenarios where a patient might present for the first time with a disease, and you are interested in knowing what's the chance that that patient is going to have something else happen to them in the future. And if you can think of any situations where you don't know right now what that probability is, then that makes for a good opportunity to solve the prediction problem. Because knowing whether someone is at high risk or low risk of that outcome might change the way that you treat them. So let me just stop here and ask, does anybody have any questions about this template of how to define a prediction problem? Okay. Stand up if this is clear to you. We're just going to make people stand up just for the hell of it. Okay, so most of you find this one clear, and so you have no questions about that one. So now, for those of you, or for everybody, now I want you to raise your hands if you can immediately think of one clinical situation that might fit into this. Can you think of an example where this might be relevant? Some people can. Okay. Okay, good. All right. Well, you're going to get plenty of time this afternoon to spend some time thinking about this. One trick that I use when, because I know many of you said early on that coming up with problems is hard to do. As I mentioned early on, so I am not a medical doctor. I have my PhD in pharmaceutical outcomes and policy. I spend a lot of time with doctors, but what I realized actually is that for me, the most valuable perspective that I gain when thinking about important research questions is not to take the perspective of being a doctor, but it's actually to take the perspective of being a patient. If you think about maybe your own experience, and maybe you have had the experience of having a disease, or someone that's close to you, a family member or a friend who's developed a disease, and to think about in those circumstances what information you would have liked to have known that you didn't know at the time. Because for me, when I've had diseases, the biggest challenge for me has been not knowing what's going to happen in the future. And if I could just know what's going to happen, it would help me decide what to do. And this prediction problem is really saying, at the time that something happens to me, what else is going to happen to me? And our data can actually support us getting us quantitative answers to that question. Spend a little bit of extra time on this one because I hope that by the end of today, many of you will have good examples of this type of question to answer. A second type of prediction question that we commonly see in healthcare is about treatment choice. So there will be circumstances where, for a given situation, there may be two options of treatments that one could consider. And the prediction problem can be specified in the following way. Amongst patients who have the indicated disease, which patients are treated with treatment A versus treatment 1 versus treatment 2? That is, the target cohort in this case is people who took either treatment A or treatment B, and the outcome cohort is the people who took treatment A. 1 and 2, those who took 1. In the case of a treatment choice problem, there is no time at risk because the moment that you make the choice is the time at risk. So it is day 0, the moment you make the choice. So an example of a prediction problem that's a treatment choice problem would be amongst atrial fibrillation patients who take either warfarin or rivaroxaban, which patients take warfarin? I don't think, a few of you stood up when I asked about which ones of you are studying epidemiology. So I'll just make a comment that might not make sense for the rest of you. But if you hear the phrase propensity score, or read that in a published paper, the phrase propensity score is in fact just a prediction model of treatment choice. That is in fact what a propensity score is. And so this problem is important to think about what this is actually doing. This prediction problem is not telling you which treatment is best for a given patient. It is not telling you that one drug gives you better outcomes than another one. Instead, it is simply predicting from patients who look like you in the past, which choice did they happen to make? And that can give you a sense of, given all of the prior patients' past choices, what is the likely choice that you would make? It's important to draw this distinction between this isn't what you should do, it's what has been done in the past. If you believe that most doctors in the past are mostly making good decisions, then you could probably think that whichever treatment that you had a high probability for might be the choice that your doctor would logically recommend, because chances are a clinician who has made the choice of giving treatment 1 in a certain circumstance will make that same choice the next time that a patient in similar circumstance comes up. So the probability of treatment choice is an example of a problem that's important in healthcare. Now, why would this matter in some circumstances? Sometimes a clinician may be in a situation where there are 2 treatment options that seem like they're both a good idea. And maybe there isn't any evidence that they're aware of to support choosing one choice versus another. This model is not going to tell you that one is a better choice, but what commonly happens in medical practice is that a clinician will consult their other clinician colleagues or ask for a referral or a specialist and say, what would you do in this situation? And that colleague would say, when I've faced a situation like this, I choose treatment 1. This prediction problem is doing the same thing as you, the clinicians, asking your friend down the hallway, what would you do? But instead of asking one clinician, what would they do? This is like asking the world's clinicians, what did everybody do? Because what you're going to be learning is the probability of choosing treatment 1 versus 2, given all of the prior choices that all the prior patients and all the prior clinicians have made when faced with the same decision. Okay. So that could be useful, not because it's telling you which treatment is best, but because it's telling you what treatment choice previous patients have made when faced with the same circumstance. Stand up if that question is clear. We'll see. All right, that one's pretty clear for about half of you. And raise your hands if you can think of a clinical situation where this prediction problem might make sense. Okay. Several of you actually, many of you can think of a situation where you might care about this prediction. Very good. Okay, excellent. You can sit down. So treatment response can also be a prediction question. And the important thing here is that we are still not determining that the drug causes an effect, but instead we can talk about amongst the people who had the intervention, who experienced the outcome that you hoped would happen of some sort. So an example of a template for this could be amongst patients who are new users of, say, some drug, which will experience the desired effect in some time window. An example of this could be amongst patients who have type 2 diabetes who start on metformin, how many of them stay on metformin after 3 years? The idea here would be that if you start on a drug, the reason you're giving the drug is because you hope that it works. And if it works, the patient will stay on the drug. And if somebody switches treatments, that's because the first treatment didn't work. So the desired effect for a chronic disease would be to take a drug and have it work enough that you stay on the drug. So this is not telling us anything about the effect of metformin, but what it is telling us is amongst the patients we choose to start on metformin, which patients are going to stay on the drug. A different way to ask, or a different kind of example of this would be that if you had some disease that you wanted to see some desirable outcome in the future, you could predict that hard outcome from happening. Let me think of a specific example. A different way that I could have defined this problem, since the goal of taking a drug for diabetes is to have blood glucose control, I could think about amongst patients with type 2 diabetes who start on metformin, which one of them get their hemoglobin A1C below 6.5 in the next 3 years. So how many of them experience the event of being under control? Okay. So this prediction problem is important because many times if you as clinicians prescribe a drug to a patient, one of the things that a patient might ask you is, what's the chance that I get better? And it would probably be good for you to be able to provide some sort of a useful answer to that question. And the answer to that question is not what is the effect of the drug. This is not an effect estimation study where we're trying to say we know that the drug works. What a patient is asking for is, what's the chance that I get better? And so this prediction problem can allow us to predict what's the chance that somebody gets better. Remembering that the green is your target cohort and the red is your outcome cohort, an important consideration is that the desired effect for it to be a cohort needs to be something that you can observe in the database. Probably the most common scenario for most diseases is when a patient comes to you, they have some ailment, and you are giving them a treatment that you expect to make the ailment go away. If they get better, there's a good chance they don't come back to you to tell you that they got better, which means there won't be anything in the database to tell you they got better. The database only has the data from the times that they come to the doctor and have issues. So when you think about defining the response, you need to think about what can you observe in the data that you can predict would happen. So more times than not, what we observe in the data are the bad things that happen to patients, because the data is coming from when you go to the doctor, and it comes from when you are complaining about some illness. However, sometimes you can think about creating a cohort where observing something, maybe it's something that's not the bad thing, can potentially be a useful a way to frame up this problem. So in this case of treatment response, the important thing to remember is that when we create this prediction, we are not making any statements about whether or not the drug is going to work. We are simply able to say, what's the chance, given that I've made the choice to give you this treatment, that you will experience the outcome in the future? So stand up if this type of prediction question makes sense. Okay. For most of you, okay. And raise your hands if you can think of a clinical situation where this might matter. A few, not too many, not as many. This one's a little bit harder sometimes. Okay, very good. Another type of prediction question is around treatment safety. So you could imagine, for example, that many treatments that you might provide a patient have side effects, whether it be drug side effects or complications due to a surgical procedure. And so in that case, we'd like to know what's the chance that those bad side effects happen. the way to define that prediction problem could be amongst patients who are new users of a drug, which patients experience that side effect that you're worried about within some sort of time horizon. So an example of this could be amongst patients who are new users of warfarin, which patients have a GI bleed in the next year. So we know that warfarin is a drug that causes bleeding. That is a well understood side effect. And as a result, as you are all being trained, you'll learn to be very careful when you give warfarin to patients, because you know that the drug, if given too much, patients will bleed a lot. This question does not tell us whether or not warfarin causes bleeding. This is going to be able to tell you whether the patient you are treating, who you are now giving warfarin to, is that patient going to be the one who's going to bleed in the next year? It turns out that while that treatment response problem is sometimes hard to do because it's hard to define good outcomes in our data because patients don't come back when they feel better, it turns out that predicting treatment safety is pretty easy, because all the bad things that happen usually result in a patient going back to the doctor. If you have a bad side effect, you go back to the hospital to complain. If you've had a surgical complication, you go back to the hospital because you're not doing well. So this type of prediction problem is quite useful, because we can look at any medical intervention and think about the fact that most interventions do have risks associated with them. Most drugs have known side effects that are listed on the product labels. Most surgeries involve very real risks of complications. So we know that most interventions have risks. But what we don't know is what is the probability of those risks. And what we really don't know is what's the probability that I'm going to experience those risks given everything you know about me. This is a very, very valuable area of research, and there are not very many prediction papers that have been published on this problem. One reason I think that is because most of the research that's been published is trying to answer the effect estimation question, which is, does the treatment cause the risk, yes or no? I would actually argue that I think it is less important to know whether or not a treatment causes a risk. I think it's much more important to patients to know what's the chance that the risk is going to happen to me. And even if it's not, we don't know whether warfarin causes bleeding, if it's the fact that I have a high risk of bleeds, that's all I really care about as a patient. Importantly, if I see that I have a high risk, it doesn't mean that what I should do is choose to not take my drug, because this prediction problem does not tell me that I'm going to bleed because of the warfarin. It is simply saying, now that I've made the decision to take warfarin, what's the chance that I'm going to have this bleed? So you cannot use this information to decide to no longer be a warfarin user. Think of it as this prediction is after you've swallowed the purple pill that you did yesterday, or the white pill. You've already committed to being exposed, so you don't get to undo that decision, but instead you get to understand what the consequence of that decision was. So it would be understanding that given that you took the purple pill, you had a 60% chance of having greater focus, but now we're trying to understand what is your individual chance of having greater focus, given that you've already swallowed the purple pill. Stand up if this problem makes sense to you guys. All right. I've lost about half of them. Okay. All right. And raise your hand if you can think of a good question that would fall into a treatment safety prediction. About half of you can think of one of those. Okay. Very good. So for those of you who aren't able to think of a good example, I'll provide a very simple hint for this. Think of any drug in the world, go find the product label that's approved by the regulator, and read that label, and I can guarantee you that label lists at least one side effect, because every drug has some side effects. So if you're looking for a prediction problem, you could simply say, amongst people who took the drug, which patients got the side effect? That is a very good prediction problem. I'll actually argue that that is a very important prediction problem, because currently the product labeling that is provided and agreed by the regulators, and product manufacturers produce it, and clinicians, you're supposed to read it, and you probably don't. That information actually, as it's currently provided, isn't terribly useful, because all it does is it says this drug might cause this side effect. But you don't get to know, or the label does not tell you generally, how often does the side effect happen, or in which patients is it going to happen to most. But this prediction problem can allow you to actually figure out how often is it going to happen, and in which patients is it going to happen most. So I think that, as many of you who are becoming clinicians, when you tell your patients to take a drug, and they are worried about taking their drug because they've heard that it has some side effects, you can think back about using prediction to be able to help that patient by saying, here is the chance that those side effects are going to happen to you now that you've taken this drug. And that might help your patients reduce their concerns that bad things are going to happen, because the probabilities might be very small. Or it might help you identify the real risks that you would like to monitor those patients for once you're treating them. All right. Another example of a prediction problem would be treatment adherence. So the treatment adherence problem would be something like, amongst patients who are new users of some drug, which patients achieve some threshold for adherence during some time at risk. So for example, which patients who have type 2 diabetes who are taking metformin achieve an 80% proportion of days covered in 1 year. This may be a little bit of a complex jargon, so let me try slightly differently. When you, for those of you becoming doctors, when you prescribe your drugs, you're going to hope that your patients take them. But they will not always take them as you want them to. In fact, many of them will not take them at all like you want them to. And yet we know that while drugs may or may not work when they're taken as expected, it turns out that drugs are highly ineffective if you never take them. So if you wanted to understand which patients are likely to actually take the drug and stay on it the way that you wanted them to, knowing that a patient is likely to do what you want them to do versus be a patient who's not going to follow your instructions, that might actually be useful. For example, if you know that you're dealing with a patient who's unlikely to do what you tell them to do, maybe you don't tell them to do something that's very complicated. Or maybe you tell them that they have to come back to the office more quickly because you have a higher likelihood that they haven't done what you've told them to do. On the flip side, if you know which patients are adherent to their treatments and are doing what you're telling them to do, then possibly you're going to have a better understanding of how they're going to respond to their treatment, and therefore you can monitor them more conservative. So understanding which patients you're dealing with, and are you dealing with the patient who's going to listen to you, or are you dealing with the patient who's not going to do what you tell them to do, might be useful for you to decide what you're going to do with those patients. Okay. So these are those same questions, just written very small again. You have disease onset and progression, treatment choice, treatment response, treatment safety, treatment adherence. All of these different questions I've never scared a student away so quickly. Yeah, I see a couple of you taking pictures. Just to be clear, we haven't posted the slides yet, but we can and will, and I don't know how we post slides, but you are putting slides up? Yes. Okay. I didn't give you these yet, so I'll give them. These will be put on your website like in the next 20 minutes.
And the book.odyssey.org, we talked about yesterday, has chapters on specific questions. Great, larger resource than the slide deck. So we'll make sure you guys have that.
Yep.
Lots of detail.
So the important thing about these, so raise your hand if you agree that these are different clinical problems. Most of you understand these are different clinical scenarios that you might face, okay? The fun part about this is that even though these are all different clinical problems, you only need to learn how to do prediction once, because all of these follow the exact same framework that we described. You need to define a T, which is your target cohort. You need to define an O, which is your outcome cohort. And you need to define a time at risk. As long as you can do those three things, we can solve the prediction problem. So this one framework for doing prediction that we've developed will satisfy all of these different clinical situations. Okay. Would you mind passing these out? Thank you. So, we are now going to do some exercises, and this is going to be for most of the rest of the afternoon. So for those of you who have been being quiet or not paying attention, it's time to wake up, because we're going to be all working together on this. What you're receiving is a form to fill out, which is to define your own prediction problem. And unsurprisingly, you're going to see that it's following this exact framework we just described. It's going to ask you to write down your target cohort, to write down your outcome cohort, to define a time at risk, and to define, and then it also says, what is your model specification? For purposes of this exercise, don't worry about the model specification yet. We're going to talk about that in greater depth tomorrow. So what the last two sections on the form, actually for this exercise I'm not going to worry about that. What I want you to do, the last question that it's going to ask you is, how will you use the model outputs to meet the aim of your study? And a way that I would like to, the way that I would like for you to think about that question is, what would you do if you could fit a prediction, if you could answer your prediction question, how would you use that information? How would you apply your prediction to the clinical scenario that you might be interested in? So the exercise that I want you all to do now is individually, every one of you, I want you to fill in this form, and I want you to come up with one prediction problem that you think would matter. So just one problem that you think is a useful problem, and I want you to fill in the target cohort, the outcome cohort, and the time at risk. And at the bottom, I want you to just write down for yourself why you think this is an important prediction problem. Okay. We're going to take, I'm going to give you probably, I'm going to say 10 minutes to come up with your own prediction problem that I want you to fill in this form. When you're done with that, what we're going to do is we're going to break up into teams, groups of 4 or 5 of you each. And what you'll be doing is you're going to present your idea to the other 4 members of your team. So that means in your groups of 4 or 5 people, you're going to hear about 4 or 5 different prediction problems. I want you to think about, as you hear those prediction problems, think about whether or not those prediction problems make sense. Do they fit the framework? And I also want you to think about which of those prediction problems do you think is most interesting. Each of your groups of 4 or 5 people, for each group of 4 or 5 people, you're going to nominate one prediction problem out of your group that you think is the best prediction problem out of your group. We are then going to capture all of those problems on the whiteboard from each of the groups and look at what those prediction problems are. We already know one prediction problem that we're going to be doing together, which is predicting lymph node metastasis following patients with endometrial cancer. But what I want to learn from everybody else is what other prediction questions you think might be as important or more important than that one. So for the next 10 minutes until 2:30, I want you to write your own prediction question. So everybody in this room needs to fill in this piece of paper. It's okay that you can write it in your own native language. This is for your own purposes to write this down. But I want you to write down your own prediction problem. At 2:30, we're going to break into groups, and you are going to talk with your partners about each of your questions. And then at the end of some period of time, which I'll decide, you're going to pick one problem, and then we're going to capture them all on the board. Is the exercise clear? Raise your hand if it's clear. All right, most people are clear. Okay, so you have till 2:30 to please fill in your form. And if you have any questions, just raise your hand and I'll come help you. How could I just raise the screen? Can I just raise the screen up? Thank you. You can steal some of my juice. Yep. Oh, that's a good idea. Actually, plug that right here.
I just was afraid people would come up, but I don't think anyone's coming to me. Thank you.
So let's see. I think I'm going to do it this way. How about the 5 of you guys together? Okay. And maybe the 5 of you. Okay. You 5 together. I'm hoping at least somebody has filled in their form. Very good. All right. How about you come join this group back here? So maybe the 5 or 6 of you will be a group. How about these 2 rows? You guys could be a group. I'm going to come around here. So let's see. So you guys are all one team. Actually, I take that back. How about the 4 of you? The 4 of you work together, and then you 2, can you work here? So you be a team. All right. Then, let's see. Could I ask you to be part of this group, the 4 of you? And then you 4 can be together. Sound good? All right. So you're going to take probably, I'm going to guess that it's going to take about 15 minutes or so. So I need you to each present your idea. I want you to hear you guys talking about whether those are good ideas or not. And then I want you to pick one from your group that is the best idea. All right. I deliberately didn't put you guys in a group.
Well, we already talked about it.
I assumed that you'd good. So you might find it. Hopefully you each individually came up with a good question, and as a group you came up with your best question. So what we're going to do is going to go through the best question from each of your groups. So each of your groups is going to have one person stand up and share with the group your research question. And I'm going to try to write it on the board so that we capture all of them and we can talk through them. Okay? So who would like to go first? Raise your hand if you'd like to go first. All right. All right, we've got... Pre-diabetes, okay.
And our outcome is diabetes.
Okay.
So the time at risk is
1
1 year.
year.
Yeah. So the treatment choice will say that use the metformin intervention or not.
Okay, so let me start with capturing the prediction problem just to make sure I heard it correctly. So your target is patients with pre-diabetes and patients with pre-diabetes, if we think about that as a cohort, when is their index date of entering the cohort of pre-diabetes?
The first day, the diagnosis is like OHDSI or IHDSI. There are blood group level meet the criteria.
Okay, so the index is when they meet the lab threshold for glucose impairment. So the moment that they hit that threshold, that's when they are considered pre-diabetes. So at that moment, we're going to use all the information before that moment in time to try to predict the outcome, which is development of full type 2 diabetes.
Yeah, actually maybe they have 3 different outcomes. One is reverse to diabetes. The other is stay as pre-diabetes. And the third outcome is reverse to normal.
Okay.
Also, this is reverse to diabetes or not.
So one is we could predict patients with type 2 diabetes. And I need more space here. Okay. So the time at risk was one. Okay. So from time 0 through 1 year. And you're saying maybe you want to go or all the way to 2 years. Okay. So one possible outcome is people who have prediabetes, which patients go on to get to type 2 diabetes. And you mentioned another one, which is patients. Well, so let's think about that one for just a second. When we have an outcome, the outcome has to be an event of some sort. So you have to have an index date for that event. So there could be a moment that you get type 2 diabetes, and that's what you would be predicting. If you don't get to this event, it means you were in this cohort, but you never get to here. So I think that you're basically predicting that you either get to type 2 diabetes or you don't, which would be that group that I think you're saying is the stay in. Yeah. Okay, so some people you might reverse to normal. So how would you find a person who reversed to normal? Lab test, okay. So a second outcome we could look at would be patients reverted to normal. Normal glucose. And that's going to be based on future measurement. Value. Very good. Okay. In the same time. So basically you've got for these group of people, there is some people who are going to get worse and they're going to get to type 2 diabetes. And then there's some of these people that maybe get better and then they have a normal lab. And so we could predict those things. They're in between those two. Yep. That makes sense. Yeah, so I'm not putting that down because that's kind of that's what happens if you don't hit one of these two outcomes, right? Yes. You either go in this group or you go in this group, or if you don't do those two things, you remain in that pre-diabetes state. Yes. Yeah, very good. Excellent. That's a great problem. So in a prediction problem that we might be interested in, so long as we can observe pre-diabetes and we can observe these outcomes, then possibly we'd be able to predict which patients are going to go from prediabetes to diabetes. And that could be quite useful in this time horizon. Excellent. Next group. Yes.
On behalf of our group, we choose this one topic, and our topic is for among those people who had the gastric cancer, grade 3. In those people who, under the operation of this gastric cancer, who radically get those tumors off.
Okay. Okay. That's your target cohort. Okay, so let me start with the target cohort to make sure I got it correctly. So we're talking about patients with grade 3 gastric cancer and have a surgical resection and they've had chemotherapy and for those patients the outcome is disease-free survival. Okay, so I'm gonna just put this in quotes here. Disease-free survival. And what is the time horizon here?
Half a year and a year.
Okay. So from the index date is the date of the surgery.
Yes.
So the index date is the surgery. So it's from the surgery to 6 months. And then you're also interested in a year. Okay? Very good. Excellent. So to go through this question as it relates to the use of electronic health record data, one of the challenges in cancer research is this idea of disease-free survival. Because think about defining the outcome cohort and how I said that a cohort has to be based off of an event that you observe. It is hard to know what the event that you observe is when you have disease-free survival, because disease-free survival should be the lack of disease and the lack of death. One way that people have done prediction problems is to switch this to be disease progression or death. So I'm actually going to just pivot this over. Okay? I'm just framing the problem the opposite way. Instead of saying who has disease-free survival, I'm saying who has disease progression or death. Because a probability is the likelihood of something happening. It's either if you have this, you don't have that. So these things are the opposite of each other. So if I define disease progression or death as my outcome, now I can look in the data to observe it. And I can specifically look to observe something like I need to define what is disease progression, and it would probably be something like a secondary cancer. So you might see a diagnosis of a secondary cancer, or if you had it in the data, you might see disease progression being something like you started at grade 3, so maybe you observed that you're now at stage 4. For example, if that was something that could be observable. Or you could measure tumor size and see that it's grown, or something like that. So, or an increase in tumor. But the important thing is to think about what could you observe in the data that you can then predict. And if this is okay to predict disease progression or death, because if you have the probability of that, then 1 minus that probability is the thing that you actually are interested in studying. Does that make sense? Okay. Very good. Excellent. So that's a very good question. Maybe could we write these down in a document? You're typing them? Awesome. Great. Excellent. Because I'm going to have to erase, because I'm not going to fit them all on the board.
My target cohort is the children with Kawasaki disease.
I'm sorry, which disease?
Kawasaki disease.
Cardiovascular disease?
Kawasaki.
Oh, Kawasaki. Yes, I'm sorry. Kawasaki disease. Okay, I'm sorry. Yep.
Using aspirin.
Using aspirin?
Yes. And our outcome cohort is the children with coronary artery aneurysm.
Excellent. Okay. So let me just make sure I captured it. So patients with Kawasaki disease who are taking aspirin.
Yes.
And that's all right. I'm going to bring it up a little bit. And the outcome is coronary artery aneurysm. And what's the time at risk?
8 weeks.
8 weeks?
Yes.
From the start of the from the start of the drug to 8 weeks. And so why is this clinical question, why do you think this matters?
Because coronary artery aneurysm is the most serious outcome for the Kawasaki disease. So we have to use many drugs to prevent it.
Got it.
In clinic, we use the most prevalent drug we use is aspirin, but it doesn't make effect for every
Sure.
organ. Some of them may become worse.
Mm. So
I wonder, do we find the children who can't benefit more from the aspirin? They have to find more drugs to help them prevent the bad outcome.
Excellent. So most patients, I just want to make sure I understand. So most patients with Kawasaki disease, we are worried about coronary artery aneurysm, so therefore we give them aspirin most of the time. But some people are still, even after getting aspirin, are still going to be at risk for an aneurysm. And those are the people that if we knew they were still at high risk after giving them the aspirin, we might give them other drugs like warfarin or something else to further prevent this bad event from happening.
Yes.
Excellent. Very good. Does that make sense to everybody? So a very good question. Excellent. Next group. Let's see. So you guys were all a group together, right? So we back up top corner.
Our target cohort was patients who had PD-1 drugs who after surgery treatment.
PD-1 drugs.
Patients who had PD-1 drugs.
After surgery. this is patients prescribed or given PD-1 drugs after surgery. And that's the outcome you're interested in?
We want to know if the patients were admitted to hospital for liver failure.
So amongst those patients, which of those patients are admitted to hospital for liver failure? Excellent. Okay. And what is your time at risk?
It should be 6 months.
From the start of the drug?
Start to after 6 months.
So from the start of the drug to 6 months. Okay? Okay, so why is this an interesting question to your team?
We want to figure out if the tumor size or age or the other medicines will lead to liver failure in such patients.
I don't know these. Which can you give me an example of one of these drugs?
For example, some patients will liver failure will happen in some patients in patients who had PD-1 drugs. But some haven't. We figure out what happened in patients who had liver failure. So we want to figure out the effects of tumor size or age or if they have other medicines when they have the PD-1 drugs.
Very good. So are these drugs known to cause liver failure? Or is it just that there's a lot of these drugs that get used?
We don't know.
We don't know. Okay.
This is what we want to know. We don't know if the PD-1 drugs will lead to liver failure. So we want to figure out what happened in patients who have liver failure after they take the drug.
Okay. So I want to, this is an important distinction that I want to draw between prediction studies and estimation studies. If you are interested in answering the question, do PD-1 drugs cause liver failure? That was an estimation question that you will not be able to answer with a prediction study. Because this prediction study is only going to be using the people on the drug to study which of those patients go on to get liver failure. So this study would be very nice to be able to tell you, amongst people that you prescribe these drugs, which patients go on to get liver failure. But it will not tell you whether or not the liver failure is because of these drugs. If you're interested in the question of does the liver injury happen because of these drugs, then we would want to design an estimation study to explore that. Does that make sense?
We want to know what happened. We think PD-1 drugs will lead to liver failure. Or we want to know what happened to such patients when they have the drugs.
Yeah, so I think that this is a good question in that we can take people who have these drugs and determine which of them develop the liver failure. And there might be lots of predictors that happen before they take the drugs that we're going to predict who goes on to have liver failure. For example, if they have a history of alcoholism, that's probably a predictor of them getting liver failure in the future. This study can tell us lots about things that, so you have a moment in time when you took the PD-1 drug. We get to use everything that happens in the person's medical history before the PD-1 drugs. These are our predictors. That's everything before the PD-1 to predict in the future which person has the liver failure. But since all of these people have taken the PD-1 drug, we are not able to determine whether the PD-1 drug had any causal effect on getting the liver injury or not.
I think the predictable effects will happen after the patient had PD-1 and so that after 6 months.
So when we train a prediction model, you have a moment in time, which is your index date, and you're only allowed to use the information that happens before that date as predictors. So if you're saying you think that things that happen after this date but before the liver injury are the things you're interested in, you're not allowed to look at those things. So so this period of time right here, this is off limits. You don't get to look at that. And the reason is think about the rationale for why this happens is because you need to think about how to use the model in practice. At the moment you give this drug to patients, you don't know what's happening to them in the future because it hasn't happened. So you don't get to use that information of what's happened in the future to guess at what's going to happen to them. You only get to use the information that you know about them at that moment in time or before. So it is, if you're interested in things that have happened in this period of time, then I would encourage you to think about how to change your target cohort to move the index date to the event that would happen that you want to predict from that moment in time. So for example, if there's something that happens like right here for all of these people, then you could change your target cohort to be able to explore that. And then you'd be able to use everything before that. What you'll see very often in the literature, like an example like this, is people will do a case control study of liver failure. And they'll take all the people who had liver failure and all the people who didn't have liver failure, and they'll try to look at differences. And they'll even call that a prediction study, but it's actually not a valid prediction study. And the reason is because having people with the liver failure and people without the liver failure and looking backwards, if I only look backwards, I don't know the moment in time that I'm trying to predict into the future. But I think the question that you've specified is a good question. There's a moment in time that patients have surgery, they get these drugs, and you'd like to know at that time, could we determine which of those patients are going to go on to have a liver failure? That's a very well-defined problem that you could explore in these data.
I think I should change I think the tumor size, the age of patients, or this information will be known before they have.
Yep. So certainly your predictors here, you'll know the person's age at the time that they took the drug. And you'd be able to see whether or not that predicts the liver failure. Absolutely. Yep.
I think I can use this model to predict
Yeah, you would not use this model to decide whether or not they should get this drug, because that is what if you wanted to answer that question, we would want to design an estimation study that determines which drug works better for certain people. So this wouldn't help you decide whether or not to give this drug. What it could do, though, is if you found people who were at high risk of liver failure, you could say, what interventions might you do to try to avert the risk of admission to the hospital for liver failure? So what else could you do?
If we know the patients tend to have liver failure after they have the PD-1 drugs, I think we can have the medicines which will protect the liver before they or when they have the PD-1 drugs at the same time.
Yeah, you could decide to add an extra drug that reduces the risk of liver injury. That would be a good possible intervention that you could consider, absolutely. Yep, that's a good idea. Yep. Very good. Thank you. Excellent. I'm going to erase that just so I got more space on the board. Next group. Let's see, got all you guys. You guys back there? Lung cancer, okay.
We divide the patients to two cohorts, and one cohort is the patient who was exposed to the high risk behavior,
Smoking.
and the other cohort is not. This is our cohort.
So are you asking amongst patients who are smokers, who develops lung cancer?
Okay.
Is that so? Your target cohort is patients who smoke.
And they smoke 3 to 10 cigarettes per day.
Okay. So patients who smoke 3 to 10 cigarettes a day, and the outcome is lung cancer. Yep.
Another cohort is not smoke patients.
So that's a different target cohort.
One is
So they have two cohorts.
Two target cohorts.
The tutorial cohort, one's smokers, one's non-smoker. Both lung cancer. And the outcome is the one we develop.
Is lung cancer.
All lung cancer, non-small cell lung cancer? What kind of lung cancer?
smoke is high risk.
那个 lung 就是肺癌有没有种呢？是就是 all lung，是所有的那个肺癌，比如说肺小细胞肺癌这种。是就所有肺癌也是 all lung cancer。
All lung cancer. Okay. So for these two target cohorts, so you're absolutely right that we know that smoking is a strong predictor of lung cancer. So when most people think about doing predictions in lung cancer, it's important to separate smokers from non-smokers, because otherwise all you learn is that smoking predicts cancer, and that's not interesting. But the challenge or the question I'd ask for your group is, how are we going to define the index date for this group of people who are smokers 3 to 10 cigarettes per day? What is the date that we're going to use to assign to that target cohort that we're going to use to look back for predictors and look forward for the lung cancer?
They smoke 1 to 3 years.
So you want to have a history of smoking. Smoking for 3 years. Okay. But how will I find an index date, that date that I will use to assign the prediction? How will I find the people who qualify for this cohort? So, for example, one way that I have seen other papers tackle this is they would say patients who have had a visit to the doctor, where at the visit to the doctor it was observed that they were a smoker. Yes. And so therefore it's patients with an outpatient visit with smoking status assessed such that now you're anchoring on the date they went to the doctor, and you know that at that date the doctor asked, "How much do you smoke?" And on that date you know that the patient said, "I smoke 3 to 10 cigarettes a day." And because you have that date, you can use the medical history before that date to predict the lung cancer in the future. Does that make sense?
When the patient visits go to the hospital to visit the doctor and every tell the doctor, "I smoke the cigarettes, 3 to 10 cigarettes per day."
Yep. Very good. Yes. Excellent. And what is your time at risk?
Time at risk, we follow up these patients 5 to 10 years.
Okay. So from the visit,
From the visit to 5 years.
from the visit to 5 years. Or possibly you could imagine wanting to do 10 years. So those are 2 different time windows you might consider. Excellent. Okay. And what about patients who don't smoke? How would you define the index date for those patients? Would you also just want them to have a visit and have the doctor ask, "What is your smoking status?" And then they say, "I don't smoke"? Got it. Okay. So it would be patients with a visit with smoking assessed and answered non-smoker. So the important thing here is you could ask me if I don't smoke. I don't smoke. But there's nowhere in any database that says that I don't smoke. There's just nothing anywhere. But sometimes a doctor asks the question, do you smoke? And you respond, I do not smoke. And the answer, I do not smoke, is entered into the electronic health record system. So you could use the people who answered the question, I don't smoke, as your index date. And that could work as your cohort to predict the outcome. What's important is these target cohorts you've defined. Many people will not qualify for either of these cohorts, because if the doctor doesn't ask the question, do you smoke? Or they don't write down the answer in the system, then we wouldn't know whether a person qualifies for either of these. But if we could observe that the question was asked and observe the answer, then this becomes a valuable study. And it's smart that you guys recognize that predicting lung cancer in smokers is a different clinical problem than predicting lung cancer in non-smokers. And in fact, when we use the data to do that prediction, it's because we happen to have done that one before, we can actually see that the predictors that you get are very different in these two scenarios. Excellent. Very good. Thank you. Let's see. You guys went. There's a team over here. You guys?
Includes patients who are newly diagnosed with stroke.
Stroke. Okay.
For the first time.
First stroke.
Yeah. Then the outcome cohort includes patients who have stroke again. Maybe at least one time. Within 3 years or 5 years.
Okay. So let me write it down. And we have a guest in the back of the room who's really quite interested in this question. So we have patients with an initial, a first stroke. There are two kinds of strokes. There's ischemic strokes and hemorrhagic strokes. Do you have an interest in one or the other? Or do you want both? Both? Okay. So with first ischemic or hemorrhagic stroke, okay? And for those patients, what we're interested in is a second stroke. And the time at risk was from the time of the first stroke until 3 years?
3 years, I'm not sure about the time. Maybe 3 years or 5 years.
So from the first stroke to 3 years, and we may be also interested in thinking about 5 years. Okay. So why is that an interesting clinical problem?
I think that for all the patients who are diagnosed with the disease, all worried about whether we will get recovered totally, or we will have
Absolutely.
So, as a doctor, we need to predict whether the patients who are diagnosed for first time will recover or they will get progression for the disease.
Absolutely. So the CHADS-2 score that is used to predict stroke for patients with atrial fibrillation, the CHADS-2 is congestive heart disease, hypertension, age, diabetes, and prior stroke. And the reason why it's CHADS-2 is because the S stands for stroke, and the 2 means it's twice as important as everything else. So the CHADS-2 score is literally you get a point for CHF, a point for hypertension, a point for being over 75, a point for diabetes, and 2 points for having a prior stroke. And that's what the CHADS-2 score, prediction score, is. This model is very important because for the CHADS-2, it pretty much guarantees that you're at high risk of a second stroke if you've had a first stroke. But the question that you're asking, which is very important, is amongst the people who have already had the first stroke, can we figure out who's going to have the second stroke? And that's quite an important question. Yeah, excellent. Okay, you guys? Last but not least.
Okay, our target cohort is patients who are newly diagnosed with type 2 diabetes.
Mhm.
And I think we should have 2 outcome cohorts. One is that people who are developing any kind of cancer, malignant cancer. And the other one is that they live longer than their life expectancy.
Oh, that they're.
I mean, they are not died from accident or something. And our time at risk, I think it should be until their outcome event.
Okay, so let's write that down. Let's see, I'm gonna. Tell you what I'm gonna do. I'm just gonna erase this don't smoker so I get some space here. And I'm gonna wedge it in here. Yeah, I'm keeping it up here. I'm just taking the details away. All right, so we have patients, newly diagnosed, with type 2 diabetes. And I heard one outcome is developing any cancer. Correct?
Yes.
And for that one, let's define what the time at risk is for that. So when is the window of time that you want to look for the cancer?
Maybe until their life expectancy. I mean, if they are diagnosed with, they are diagnosed of type 2 diabetes, their safety is maybe 20 years. But if they are diagnosed in their 40s, that's maybe 40 years.
Mm-hmm. So, okay. So it sounds like it's from the time of the diagnosis until what sounds like you're saying is you basically want to follow them until they die. Okay, I'm gonna until death. Okay. So to challenge this a little bit, if you're a patient, it makes sense that if those of you who are clinicians, if I come to you and you tell me I have diabetes, I might say, "Doctor, what's the chance I'm ever going to get cancer?" And you're saying you could provide me some probability that I'll get cancer sometime in my life. But the problem with that logic is that if I don't have much time to live, I probably have a lower chance of getting cancer. And if I have a long time to live, then I have a higher chance of getting cancer. This is actually why it's actually important to not define your time at risk as a variable length thing, but instead to define a specific window, because within a specific window, it's a fair prediction that you could give every patient. Right? Even if I asked you, I want to know what the chance of me ever getting cancer is, the truth of the matter is you can't answer that because you don't know how long I'm going to live. But if I say, what's the chance I'm going to get cancer in the next 5 years, you can answer that because we can look at all people like me and see how many of us got cancer in the next 5 years. Does that make sense?
Yes. Then in this case, I think I should change my target cohort. Maybe my target cohort should be patients who are newly diagnosed with type 2 diabetes before their 60s, and then I can create a time window.
So you want them to be less, who are less than 60 years old. Okay? And if that's the case, what do you want the time window to be?
20 years.
20 years. All right.
And do you have data where you work that follows patients for that long, continuously? Is there a lower amount of minimum time at risk?
Got it. Yeah, so this, there are many questions that we would like to study to try to predict long-term outcomes, but the reason Kristin's asking that question is the longer the time at risk, the more demands you are making on your data, and it means the less data that will be available to actually help you with your problem. And so if you think about wanting 20 years of follow-up time, so let me draw the picture here. You have a date that someone is diagnosed with type 2 diabetes. You are now asking for 20 years of follow-up. But of course, we're going to use predictors in the past. So let's say that you wanted to have 3 years of medical history in the past, let's say. Okay. So now, in order to do this study, you need to have patients in an electronic system for 23 years. And we're currently in 2019, which means that this goes back to 1999, which goes back to 1996. So people could enter the cohort no more recently than 1999. They could enter any time before, but it means we need to have data that starts in the early 90s in order to predict this outcome, which could go all the way up to now. And one challenge with doing a long time horizon like this is that we have to believe that the disease hasn't changed, or the management of the disease hasn't changed in this entire time. But of course, we know lots of new drugs for diabetes have been brought to medicine. We know that in about the 2000s, that's when the the TZDs were introduced, and around the early 2000s was when the GLP-1s were brought in, and about here was when the SGLT2 drugs were brought in. And so we now know that treatment of diabetes is very, very different in 2019 than it was back in 1999. And yet the model, the prediction model that we would be training is to assume that what we learned on people with diabetes back in 1999, that we could use that to treat patients in 2019, which is a challenge because it means that you have to believe that this is the same. So one reason that you'll see most prediction studies that are published use shorter time windows, in part it's because it turns out predicting things in the short term is easier than predicting things in the long term. But the other reason is because long-term predictions require long-term data that we just often don't have. So it makes good sense why you want to answer this question, and it makes sense if I'm a patient and I come to you and I say, "Doctor, what's the chance I'm going to get cancer in the next 20 years?" that I might want an answer to that. But very often the answer would probably be, we can't predict that far in advance, but instead we could predict whether you're going to get cancer in the next 1 year or 2 years or 5 years maybe. But going that far out, it represents a challenge for most of us. Yeah. You had a second outcome as well?
Yes, my second outcome is that they are live longer.
Oh, live longer. Okay. So how would we think about defining living longer?
Live longer maybe than 20 years.
Live longer than 20 years. So basically, maybe to frame it a slightly different way, death could be the outcome, because we could say, how many die in 20 years? If you don't die in 20 years, then you're alive, which means you've made it to your 20-year horizon. So because we know death is an observable event, we could produce the probability that you die in 20 years, and you would know whether or not that was high or low. And so that actually works very well. Excellent. Thank you. Very good. Okay, so let's bring this. Did I get all of the groups? Okay. All right. So, tomorrow we're going to stay focused on Bonnie's question, which is predicting endometrial cancer, predicting lymph node metastases in endometrial cancer in 1 year. But each of these questions that you've come up with here are all good prediction questions. And what I hope that you got from going through this exercise is that all of them follow the exact same process. You define a target cohort, you define an outcome cohort, and you define a time at risk window. If you can fill in that piece of paper, then you can define a prediction problem. what's important, and the conversation we've just had about each of these questions, usually the conversations basically come up to how do you define your index date for your target cohort? Because that index date that you're defining here is really what drives your prediction problem. Because you only get to use the data before that index date in your prediction to predict an outcome that's going to happen after that index date. So for some of these, it's patients with pre-diabetes, so that the index is when you met the lab threshold for glucose impairment. So that particular problem, I could imagine a challenge that we will see is that people have laboratory measurements repeatedly, and sometimes they will be in the pre-diabetes state, and sometimes they won't, and sometimes they will again, and sometimes they'll have repeated measurements in that pre-diabetes state. So we would have to be very precise to be the first time they ever met that threshold. And we would need to think about, what if a person had one time where they had a glucose that was in the pre-diabetic range, but you never observed it before and you never observed it again afterwards? Do you really believe that person is pre-diabetes? Or do you think that they just had a bad laboratory measurement on one day? That is a challenge in data that we have to work through sometimes. But nonetheless, we could define an index and we could consider that. Or we could say that in order to ensure that that person really is a pre-diabetes patient, that perhaps we require 2 laboratory tests to be in the pre-diabetes range, but then we would need to define the index date to be the second of those 2 laboratory tests. Why? Because we can't use the first one, because the second one is an event that happens in the future. And I wouldn't know that the second one was going to pass. I would need to wait till the second one happens in order for it to be something in my past medical history. So defining the index date is really important for these things. The gastric cancer example, the index date we cared about was the surgery, or the day that the surgery happened. Was that right? The Kawasaki disease, it was the day that they started taking aspirin. So this is their index. This is the day that they started taking their PD-1 drugs. This is a random visit when they were asked the question of their smoking status. This is the day that they're first diagnosed with type 2 diabetes. And this was the date of their first diagnosis of a stroke. Okay. So the main issue that comes up when defining prediction problems as it relates to the target cohort is to define who are the people we want and what is that index date. The outcome cohort, it's also important to make sure that you get the index date correct for your outcome cohort. So when do you enter the cohort of the outcome? That is important, mainly because you're going to be checking whether that index date of the outcome occurs during the time at risk. Okay? So the reason why it's important to get the date right is you're going to be using the date to define the prediction problem. So by comparing the index date of the target cohort with the index date of the outcome, that's going to tell you whether a person qualifies for the cohort or not, or for the study or not. The last thing I'm going to highlight is how you defined time at risk. Remember that time at risk is a duration of time. There's a start of when you're at risk, and there's an end of when you're at risk. That's why you see that I wrote every single one of them as from a moment in time to a moment in time. Interestingly, all of your prediction problems, you started the time at risk the immediate day after the index of the target cohort. But that is not a requirement for a prediction study. In fact, tomorrow when we talk about your question, Bonnie, one of the things that I will challenge you on, so you can think about it as homework, is what would happen if a person had endometrial cancer today and they got a lymph node metastases tomorrow? Is that really the event that you're interested in? My guess is no, because cancer doesn't go that fast, right? Realistically, if you saw the endometrial cancer today and the lymph node metastases tomorrow, it probably means you observe them both at the same time because you just missed it. But it's so more likely is that what you care about is endometrial cancer, and there's some period of time where you don't expect to see a lymph node metastases start, and you're going to be looking for new lymph node metastases after that period of time. So it's okay to start your time at risk any time after the target index date, and it can follow until whatever time you're interested in. You can go as long as you want, but remember, the longer you go, the more demands you're putting on the data, and the harder it's going to be to actually solve your prediction problem. That's why very commonly you'll see that we'll do predictions of 1 year or 3 years, because there are many databases out there that can allow us to answer that kind of question. As you go out into 10 years and 20 years, many databases will not be able to support that type of research. Any questions? We have like pretty much had time, right? We still have 25 minutes? Oh, I thought it was 4:10 we're supposed to go to. What's that? I thought it was 4:10. What time does class go until? I'm at time, right? Okay, good. Okay, so is there any questions? Okay. If not, you are going to have one homework assignment tonight. Lingyi's going to post an article that I'd ask you to read. It's a paper that describes the entire prediction framework process. The reason I want you to read it, you'll read something about this, but it's also going to introduce the idea that you can apply different models and different features to try to predict the problem. I'm going to describe those pieces tomorrow as we go through the modeling example, but you will find it prediction. So I'm going to have Lingyi post the paper. I ask you to read it, and we will use that paper tomorrow in class. The fun thing about that paper is what you'll see is how we can actually predict many different outcomes from many different target groups using many different models. And in fact, you'll see in that paper that we're able to predict very important clinical events, such as which patients, amongst patients who are depressed, which patients will attempt suicide. We were able to show that we could predict that with very high accuracy. And that could have very profound impact for saving the lives of patients if we could implement that into clinical practice. All right. Thank you all. I will see you tomorrow at 8:55. Enjoy reading our paper. And tomorrow, be ready, because we are going to write Bonnie's paper and have a medical journal article about endometrial cancer and predicting lymph node metastases by the end of tomorrow. All right. Great. Thank you.